so we went to grab a seat. So we're really very lucky to have Dr. Silber come and speak. Definitely we've grown over the years with our fetal counseling, but we've always turned to Dr. Silber for our most complex cases, and he's been gracious enough to go over specific cases in the past. He can talk to families directly, and we appreciate you coming and talking a little bit about how you go about assessing a case. How do you deal with these ethical issues about the postnatal management of particularly the more severe congenital anomalies. So thank you, Dr. Silber. And there are people who have called in from St. Elsewhere. Please be aware that at the end of the presentation, we will have time for questions and answers. And for those who are just calling in, you also can ask questions if you wish.
And my associate, Meg Menzel, who's also a member of the Clinical Ethics Committee, that happens to be the genetic counselor working with you, will introduce the case that I will comment on.
So our talk is entitled Ethical Issues Surrounding the Postnatal Management of a Severe Congenital Anomaly. And we have
you have reached the desk of Dr. Mary D'Onofrio. I'm unavailable at this time to take your call. Please feel free to leave a message at the beep. If this is an emergency or you need to speak to me immediately, please.
We have 3 learning objectives today. Participants will learn about foregoing life or withholding life-prolonging care as outlined by the AAP, the AMA, and the NRP. We'll reflect about a selected case of a fetus with serious congenital malformations, to be followed by a review of the prenatal consultation, the parent's experience, and related ethical aspects. And in conclusion, 7 practical items adapted from the Mercy Hospital Ethics of Delivery Room Care will be presented as a model that can be relevant to the ethical approach to fetuses and infants with a very serious congenital malformation. So I'm going to present a case that is somewhat from reality and somewhat from bits of other cases brought into it. It's impossible to do what we do and not be emotionally affected by our cases. Often we simply feel sad or empathetic with our patients, and sometimes we feel proud of our patients and admire our patients, and sometimes we may even feel dislike for or angry towards our patients. It's our job to keep these emotions in check for the most part when interacting with patients, but sometimes our feelings linger and weigh on us after meeting with a family. The cases that linger are often the ones for which we find or feel an ethical dilemma. This may involve questioning the patient's beliefs and decisions, or our own counseling and actions. The case I'll present today is a case that is created with bits and pieces of cases that all share in common.
You have reached the desk of Dr.
At some point they cause some angst among members of either the prenatal or postnatal care teams. And as you hear the case, you may or may not find that it poses an ethical dilemma to you. So this is a patient who was referred at 21 weeks for MRI, ultrasound, and neurology consultation with a prenatal diagnosis of an open neural tube defect and hydrocephalus. So pretty significant findings at 21 weeks. The ultrasound and MRI findings included, again, the open neural tube defect, also a VSD, bilateral club foot, and abnormal positioning of one hand. The family was counseled by neurology and the genetic counselor regarding the open neural tube defect and concern for increasing hydrocephalus, in particular at this early gestational age. The likelihood of an underlying genetic syndrome was discussed, and the option of amnio was discussed. And the family inquired about in utero repair for an open neural tube defect, but they were told by the team that the cardiac defect would disqualify them from being a candidate. The family then went ahead and did research on their own, called several centers around the country, and they were able to find another fetal surgery center who told them that the cardiac defect would not necessarily disqualify them.
I know where that center is.
But that a normal karyotype was necessary for the in utero repair. The family, because of this information, then opted for amniocentesis, and the karyotype was consistent with so all of you know about trisomy 18, but just a very quick review. Chromosome abnormality involving an extra chromosome 18 in all the cells, more than 130 different congenital abnormalities associated with it. Approximately 10% of babies diagnosed with trisomy 18 in the second trimester will die in utero, maybe more. Generally considered to be a lethal condition, defect. Less than 10% of fetuses with trisomy 18 have an open neural tube defect, but some do. And in general, we talk about 50% of babies die within the first year, but 90% will die within the first year.
Last year, it was open to all, so I'm hoping
of
in the first row.
Of the less than 10% who survive the first year, the majority will have no ambulation or verbal communication. Some children can smile and laugh and interact in this regard with their families. So the reaction to this diagnosis from the family was they were disqualified by the center that they had gone to for any type of NTD repair given the trisomy 18 diagnosis, and they were very, very upset about this. They felt that that was not fair, that just because the fetus had trisomy 18, they would be disqualified from the surgery. They kind of wanted to be a test case, and so they were angry at that center. The diagnosis and the ultimate lethality of the diagnosis was discussed with the family, and they seemed to understand the diagnosis and its implications.
Please put yourself on mute if you're calling into the conference. We hear a lot of background noise.
So the next step was to talk with the family about delivery planning and what their wishes were. So they returned to meet with a neonatologist and the palliative care team to discuss delivery planning at a nearby hospital. They indicated that their birth plan was that their wishes were for a C-section delivery and immediate transfer of the baby to a children's hospital for surgical management of the open neural tube defect and the hydrocephalus. The cardiac defect wasn't as essential in terms of needing immediate attention at birth. All teams at the delivery hospital and at the children's hospital were made aware and were supportive of their plan. So the baby was born by C-section, CPAP was administered, the baby was baptized and transferred to the children's hospital. On day 2 of life, the neurosurgeon repaired the open neural tube defect and the baby was placed on an external CSF shunt. At 1 week of age, the baby had a VP shunt placed, and 2 days following the placement of that shunt, the baby was still intubated and the wound was leaking. At 2 weeks of age, the wound from the VP shunt dehisced, exposing the shunt tubing. Neurosurgeons removed the shunt and placed an EVD. Family expressed their wishes to continue with this type of care to give the baby every possible chance to survive, but expressed interest in having this done with limited suffering. The mother expressed the goal of having skin-to-skin contact with the baby and bringing the baby home. The parents ultimately opted for removal of the EVD following discussion with the neurosurgeon about the fact that other surgical management options were highly unlikely to be successful. So essentially the neurosurgeon kind of declined any other neurosurgical options for this family and did not recommend any of them. Their family then requested a second opinion from another children's hospital about the benefits and risks of this other neurosurgical procedure. At 5 weeks of age, the family did bring the baby home to be with them with the support of a home hospice care team. They then traveled with the baby to another city within a few days of being home for a second opinion with another neurosurgical team. They were deemed ineligible for the procedure there, and the baby passed away very shortly after that trip within about 2 weeks of coming home.
Thank you very much. Any questions about the case for me? I think you presented, it came alive, didn't it? Well, I will start by mentioning the current policies of neonatal resuscitation of the American Academy of Pediatrics that were established in 2007. And of course, they say that the appropriate course of action is based on the best estimates of the infant's prognosis. So when early death is very likely and there's a high risk of severe morbidity, intensive care is not indicated. When survival is likely and risk of unacceptable severe morbidity is low, intensive care is clearly indicated, my emphasis, and cases that fall between with uncertain but poor prognosis referred as to the gray zone, parental desires should determine the treatment approach. So this particular case is a very sad case, but it really falls into more the first category. Early death is very likely, rather than the third, which is what the parents were saying. So that's from the perspective of the AAP. Oh, which one is it?
Yep, that's right.
This one.
Yep.
From the AMA, it's a bit similar. The primary considerations: what is best for the newborn? One, that the chance of therapy would succeed, the risk involved with treatment and non-treatment, the degree to which the therapy, if successful, would extend life, the pain and discomfort associated with the therapy, and the anticipated quality of life for the newborn with and without treatment. It's interesting that the AAP puts a lot of emphasis on the parent's opinion. The AMA directs itself directly to the doctors. It probably assumes that the doctors talk with the parents and take this in mind, but it's not mentioned. This is a little bit older. Wow. What do you know?
Good question. Let me get out.
Let's see if I press here what happens.
Ron Dixon disconnected the call.
Oh, Ron, killing me. Well, I can still see it in my room.
There we are. The next, yeah, that's fine. You're in the right one. The National Resuscitation Program gives specific situations in which it is ethically permissible to withhold resuscitation. Gestational age, they mention, parameters, birth weight, congenital anomalies, our case, coupled with early death and high morbidity, and they give examples: less than 23 weeks, less than 400 grams, anencephaly, confirmed trisomy 13 or 18. However, guidelines, be it from the AAP, AMA, the NRP, simply educate us to a logical way of thinking about it. It's not the end-all. Every case is different, and we're going to address that now. People have had other criteria for when to resuscitate. You know, they use physiology scoring systems, clinical intuition, appearance in the delivery room, multifactorial approaches, female gender, singleton gestation, antenatal steroids, etc. So the reality is that we cannot do a dictum about what to do, but a way of thinking about what to do. Since the AMA and others have not put in a parental perspective, I think this is an area that needs work. Studies about how parents see this have shown clearly that parents want to be involved in resuscitation decisions, that they often don't understand their options. Even more strangely, they do not recall discussing options with medical providers. When you study them, like Boss in Baltimore had done this study that she published in Pediatrics in 2008, then saw that physicians charting for these patients indicated that the options for delivery and resuscitation were discussed, and the parents had no recollection. There's no explanation for this phenomenon, but there are speculations. One speculation is that the parents are so overwhelmed, so tense, and so upset by everything that's happened that the whole experience is a whir, and they can't listen appropriately, and so miss out. The other possibility is that many of us doctors have been trained in a certain language, and we speak medicalese, which is very clear to us, so we put it into the record, but may not be clear at all to the parent, who nods an understanding because of being respectful to the doctor, but it's not real understanding. So that's an important issue to take in mind when looking at the parental perspective. Studies were also done about what the parental expectations are, and in general, parents, like in this case that we discussed, are more positive than physicians regarding outcome, so this should not surprise us. They do go through a period of grief because this discovery of a congenital anomaly shifts the parental identity, so it crashes the image that they have of a normal family. What do they make their own decisions? Very often it's religion, but it could be some kind of spirituality or simply hope. And the hope becomes little and little. They hope for this and this and this and whatever, you know. There was a mention there of babies with trisomy 18 smiling in response to the parents, and sometimes that's all that they finally hope for. Parents desire clinicians to demonstrate compassion and provide emotional support rather than those who counsel on the basis of a protocol. And by that is meant that if the protocols given by the different societies are adhered to in a scientific way, one doesn't do anything wrong, but it's not, doesn't gel with the parental expectations. And I know everybody in this team, because I know you guys do meet the parental expectations in that area. So what's important is how to frame the prenatal consultation. The physician's framing of medical prognosis is very important. One thing that I didn't put in this slide, but that I see in some services, is that parents get discordant prognosis because of the number of people involved. And of course, people are entitled to have discordant prognosis, discordant ideas about this, based on their experience on what or how the patient changes. But it's very important that if that's the case, that a lead person describe honestly the different points of view, rather than leaving it anarchic and for the parents to hang on to whatever has been said. The other thing is, well, if you give the parents a prognosis that is reasonably good for survival, the parents will choose resuscitation. Now, when that is honest, that's fine. Then, if the parents are told that the chance of death and disability is very big, negative framing, they will often choose not to resuscitate. So it puts the person that gives the prognosis in a very powerful position. Nothing wrong with that, but we have to be alert about this influencing. And sometimes, as I'll go on later on, influencing is perfectly ethical and legitimate. But we just have to be alert to that. Quality of life is it, whenever we have a case, we always discuss this as a very central element. Well, the AAP uses poor quality of life as the basis of non-initiation or withdrawal of intensive care for these high-risk newborns. It's important here to notice the many papers by Siegel in which they measured quality of life of survival of neonatal intensive care patients. And doctors and nurses felt the same way about it. Parents did not. And when they studied, in other words, parents accepted a quality of life that doctors and nurses would not. And the other thing that she did, which was very intelligent, she actually interviewed with control group teenagers that were survivors of these neonatal bad and very terrible illnesses, and there was no difference, according to the kids, in the quality of life of kids that really had suffered tremendously with all kinds of neurological impairments and the general population. Now, could it be denial on the part of those teenagers? Could it be that they were much more sheltered and taken care of than teens in the general population? But for whatever reason, the quality of life issue is one that doctors and nurses, we may have a different view, and we have to be careful in our analysis of quality of life. I'm not saying that we shouldn't consider it, but we should consider that others think differently than we do. Of course, the thing that would have been ideal in the case that we presented would be the option of comfort care. And basically when we offer that option, what we do is we assure parents that this is acceptable and a compassionate decision for the infant, that this is part of the practice of medicine, and that they need to know that they will be supported, and that there is a primary goal to shift to comfort and peace at the time of the end of life with the family. And many families are ridden with guilt, and they have this different experience than the way we see it, which is that they feel that if they consent to this, they're killing their child. And that is one of the reasons behind the movement of changing, which we did at Children's Hospital, of changing DNR to A&D, rather than a negative thing, do not resuscitate, which sounds so cold. Allowing for a natural death is congruent with the experience of how we all died, not that long ago, So this is where, very often a favorite nurse, a social worker, a trusted doctor, etc., can make such a tremendous difference on how they perceive this. Basically, what parents want to do is they want to be good parents. And the message that we will give them is a good parent that can let go. So, the ethical principles involved in these prenatal consults are no different, really, than in other areas of medicine. There are many ways of looking at ethics, but the one that's traditional in the United States, and believe me, there are many other competing ones, but it helps us, are autonomy, beneficence, non-maleficence, and justice, which are basically what we call the Georgetown mantra, because this was developed by the bioethics group at Georgetown. Well, of course, newborns are unable to exercise self-determination, so they have a surrogate, and the best ones are usually the parents. What is expected of the parents is to act in the best interest of the child. The tension between beneficence and non-maleficence is the treatment dilemma, which is often enhanced by the difficulty with prognostication. In the case of a trisomy 18, there's less difficulty with prognostication than in other situations, but still, you don't know which is the kid with trisomy 18 that will live longer. Many of these lethal conditions are called lethal conditions because you don't treat them. And, if you would treat everybody intensely, there would be a higher percentage of survivors. So, to put it all together, I like practical applications because I do ethical consults. So in looking at many different practical approaches to these terrible situations, I like the group in Kansas, Children's. They have developed 10 points and they presented them recently in an article in the Seminars of Fetal and Neonatal Medicine, and they basically discuss it as ethics of delivery room care. And from those 10, I adapted 7, which we have here, to accept the gray zone, to consider that dying is not generally in the infant's best interest. Impairment does not necessarily mean poor quality of life. Just because resuscitation was not initiated does not mean that one cannot withdraw treatment. Respect powerful emotions, be aware of self-fulfilling prophecies, and of course, what we do very well here, never abandon parents. How much time do I have?
You can keep on going.
Okay, because I could develop each, a little bit of each one. The first one, be okay with the gray. Complex decisions deserve individual analysis, and that's why any of the guidelines that I mentioned at the beginning is an important thing to know, but we still will do individual analysis. Attempting to create broad black and white categories for all newborns with severe congenital malformations is taking the easy way out. So yeah, we have to accept the gray zone. So in this case, my preference would have been to work with the parents, frame it, and help them accept not to do anything, But we have to accept that for them, that's the gray zone. Well, dying is not generally in the best interest. That's kind of tongue-in-cheek, right? But the burden of care and quality of life are important considerations, but allowing a trial of life can be a reasonable option. What the Kansas group says, and I quote them, the baby will never have the opportunity to confront future obstacles to care if one doesn't a trial of care. But the trial of care is not obligatory. It's just an option that one can discuss. As I mentioned before, impairment does not necessarily mean poor quality of life, and basically one cannot be the judge of somebody else's prospective quality of life. And the fourth, just because the train has not left the station, it does not mean you can't get off. And, just because the infant has been resuscitated in the delivery room does not mean that tracheostomy, gastrostomy, and other surgeries have to follow. Discussions about care can be ongoing, and parents and medical team can, of course, alter the course of treatment. From an ethical perspective, withdrawal of care is ethically equivalent to withholding of care. The same reasons that would support withdrawal apply to what one reasons for withholding. And the powerful emotions reveal moral truths, the moral truths of the parents. But not all burden should fall on the parents. So it is appropriate for the medical care team to be somewhat directive. Emotional feelings of parental duty may overrule logic if no direction nor guidance are provided. And this is the tricky part, because it has to be done, you know, like when you dance a tango, you know, it has to be done in a way that the parents don't feel that you want to follow your own agenda, but you're guiding them based on your knowledge of them and their situation, but you're very willing and open to accept that your guidance is not what they need at that time. In ethics consult, what we always do is we try to make a bigger circle of people that are involved so the parents don't feel a total burden. So often it's good to, if they're religious, to bring in the chaplain, or grandparents sometimes may be able to help them through this with their experience of life. Be aware of self-fulfilling prophecies, as I mentioned before. Parents request that treatment be provided for kids have resulted in longer lifespans. Not great lifespans, but longer lifespans. And that's what they or the little older brother or older sister may feel is important. And of course, we never should abandon patients. Parents of NICU babies are on an emotional roller coaster. They may behave badly. Some get angry. Some do not visit their children. They're too distressed. Some can be very intrusive in the care of the kids. And some are very critical of the staff. And nevertheless, they still are in need of guidance. And the parents who are most difficult to get along are often the ones that might need support the most, not surprising. So this is kind of a bird's eye view of this kind of situation, and we're ready for questions or concerns or experiences that you may have had that we can discuss. Yes?
I have a question about these, the NICU survivors quality of life assessments. It's a very biased population because the people who are NICU survivors who are completely nonverbal or unable to sort of respond to that can't give you a quality of life assessment. So you're, by definition, having really only the highest functioning survivors who are going to weigh in on that.
Right. Yeah.
So I mean, I think it's a false comparison group to say, oh, well, look, these kids have the same quality of life, but only the
ones
tip of the iceberg.
Yeah, quite. Some
question.
of them were quite low in their functioning, but sufficient to be verbal. But the parents of those that were really in pretty bad shape also were part of the study. It's not only one study, it's several studies that Segal has done. And when I read it, I was really surprised, but it's evidence-based and has been repeated by other scholars too. So we humans sometimes adapt ourselves and our expectations diminish, and whatever we can get, we can get. You know, it's like a bit like the cancer patient who gets metastasis and so on, but one more day, you know, we adapt. Now, the question is, how happy would this family have been? How would they have functioned if they would have let go and then they would have had another baby and be, you know, a more average family, etc. Some of these families say interesting things, because I've spoken with many, such as, this kid has given us a lot. And I think by what they mean by that is the generosity of spirit, the dedication to another human being that is diminished is perceived as a gift.
I have a question. In one of your slides, you mentioned female gender as a factor.
Yes,
didn't
because
understand what's the
in many, especially in the viability literature, girls that are clinically very similar to boys survive. I don't know the explanation for that, but it seems to be that the weaker gender is the stronger one. But that has been shown universally, not only in the United States. There's something about girls that makes them, at that age, more resilient. We don't know what it is.
Are there any other questions from those calling in? Comments? Okay, great. Thank you very much, Dr. Silber.
Thank you so much. Bye.
Wonderful.